Now, a bit about instrumental swallow studies. They give us a visual of what's actually happening inside a person's throat when they swallow. Without that visual, we're left to guesswork. Speech therapists do what's called a bedside swallow evaluation or clinical swallow exam, and it's relying on what we can observe and hear outside of the patient's throat. At no fault of the therapist, those types of studies are unreliable. No amount of experience can cause a speech therapist to know definitively what's going on inside the throat without getting a visual. I've experienced this myself as a clinician. I think someone's swallow is fine. The patient gets an instrumental study, and the findings radically change my treatment plan. Without an instrumental swallow study, misdiagnosis of the severity and type of dysphagia is very common. Of the 68% of patients that have dysphagia, 70% are overdiagnosed, and 14% are aspirating without the therapist detecting it. If you're thinking, why not play it safe and overdiagnose? That's essentially what happens without an instrumental swallow study. And it's not a good solution because it decreases quality of life for the patient while greatly increasing facility cost. No one wants to be on a modified diet and thickened liquids if they don't have to be. Unnecessary intensity of therapy sessions has a cost. Therapy materials and thickened liquids have a cost. And some of these interventions, like thickened liquids, actually can make aspiration more likely. Again, only an instrumental study can give the therapist the information needed for them to make proper recommendations about the patient's specific presentation of dysphagia. About the 14% who are underdiagnosed. Hospitalization and rehospitalization is the result. No one wants their customers to suffer, and income is passively lost when a resident's bed is empty because they're in the hospital. Initial stays in hospitals can be due to a disease that can directly cause dysphagia, or dysphagia can occur after hospitalization as a result of intubation during surgery, or even just from generalized weakness after a long battle in the hospital. These things make dysphagia and aspiration pneumonia more likely after an initial hospital stay. And rehospitalization, if it occurs within 30 days after discharge from the hospital, becomes the financial liability of the skilled nursing facility. Considering this, although instrumental studies have a direct cost up front, that cost pales in comparison to the long-term costs of under and overdiagnosis. So it's clearly better to have an instrumental study than no instrumental study.